cat as pets, as in our case, their food or water may get contaminated with cat feces knowingly or unknowingly, and they will develop this disease. So what could be the pathogenicity? Pathogenicity is known as toxoplasmosis, and most common presentation is asymptomatic presentation or asymptomatic toxoplasmosis. That means patient does not know and it does not have, he or she does not have any kind of symptoms. But other modes are congenital, acquired, ocular, and immunosuppressed toxoplasmosis. So let us see them one by one. So congenital toxoplasmosis it results when Toxoplasma gondii is transmitted transplacentally from mother to fetus. And this occurs when mother gets primary Toxoplasma infection, whether clinical or asymptomatic, during the pregnancy. And pregnant mothers which have this Toxoplasma infection, and because pregnancy is an immunosuppressive state, and this tissue cyst may sometimes get reactivated if mother has a latent infection. The risk of fetal infection, it rises with the progression of gestation. For example, in early pregnancy, the risk is 25% in first trimester, but it goes up to 65% in third trimester. But interestingly, the severity of fetal damage is maximum in early pregnancy, while it is very less in late pregnancy. And most infected newborn, they are asymptomatic at birth, and they show clinical manifestation weeks to years after the birth. So what are these manifestations? So I have divided them into 4 different categories. One which involves brain, eye, reticuloendothelial system, heart, and other manifestations. So in brain, it causes cerebral calcification, convulsions, mental retardation, deafness, microcephaly, hydrocephalus. In eye, it causes chorioretinitis, squint, blindness, microphthalmia, cataract, glaucoma, lymphadenopathy, hepatomegaly, jaundice. It can also be seen, and myocarditis, fever, petechiae. These are the various manifestations of congenital toxoplasmosis. So here I have shown you the ventriculograph of skull, and as you can see, there are calcification in ventricles. So cerebral calcification, you can see a child with hydrocephalus. So these are all manifestation of congenital toxoplasmosis. Sometimes it only involves eye, and then we call it as ocular toxoplasmosis. It could be seen in children, it could be in adult, and usually it is uveitis, choroiditis, or chorioretinitis, as you can see here. And sometimes it may be so severe that it require removal of entire eyeball, that is known as enucleation. Acquired toxoplasmosis, that is after birth, it is acquired postnatally. The most common manifestation is lymphadenopathy, and most common lymph node which are involved are cervical lymph nodes, as shown in the picture. Fever, headache, myalgia, splenomegaly, and self-limited mild flu-like illness can also be there. And some people may also show typhus-like exanthema, which may complicate in pneumonitis, myocarditis, sometimes meningoencephalitis, which can be fatal also. If a person is immunosuppressed, then for example AIDS, then most serious and most fatal illness can be seen, and the most common organ involved is brain, in which you will see encephalitis, altered mental status, seizures, cerebral signs, meningismus, neuropsychiatric manifestations. But it is not that only brain is involved. Other organs can also be involved, like lung, pancreas, gastrointestinal tract, eyes, heart, liver, and sometimes Toxoplasma pneumonia. And why I'm saying that, because in AIDS, when we say pneumonia, the organism that comes to our mind is Pneumocystis candi pneumonia, but this could also be one of the cause. If you see the CT scan, then you will see ring shape enhancing lesion on the contrast CT scan in case of cerebral toxoplasmosis. Immune response, the humoral immune response in form of IgG, it will act only on extracellular trophozoite. It cannot kill the trophozoites which are within a cell. Cell mediated immunity is very important to kill the intracellular morphological forms, and in which T cells and natural killer cells play a major role. How to diagnose in lab a case of Toxoplasma gondii? So there are I have divided them into 3 portions: microscopy, serology, which is the mainstay of the method, and other. Microscopically, you take the sample. Usually it is in blood, so you can take blood, sputum, bone marrow aspirates, and with help of GIMSA or PAS or GMS, or that is Gomri methamine silver, you can stain those films and show them either bradyzoids or tachyzoids. It is as simple as that. But the mainstay of diagnosis is serology. Now here we can detect either antibodies or antigen. Antigen detection is usually with help of ELISA. IgG, IgM and IgA can be detected with ELISA or other methods. IgG detection, it is useful after 2 to 3 weeks of infection, but it reaches peak level at 4 to 8 weeks of infection, and the titer which is significant is more than 1 to 10. And IgM detection, it is mainly for acute infection, while IgA detection is very useful in case of congenital toxoplasmosis. Other infections detection methods are PCR. B1 gene detection in amniotic fluid can be very useful. MRI or CT scan to locate the lesion. Ultrasonography to detect anomalies in case of congenital toxoplasmosis. Animal inoculation, skin test, these are obsolete tests. Skin test of Frankel was used in earlier days to detect delayed hypersensitivity after 48 hours of injecting the Toxoplasma antigen into the forearm. So these are the microscopic pictures. This one is stained with GIMSA, as you can see. This one is again with hematoxylin and eosine, and it shows the cyst. And this is a new method, that is immunofluorescence, which is showing the tachyzoids. Sabin-Feldman dye test. This test is obsolete now, but again to complete the laboratory diagnosis, what is the principle of this test? That if a patient has antibodies, it will inhibit the staining of trophozoite by the dye. So what we do, we take patient serum, we add to it the trophozoites, and then we add normal human serum, incubate it for 1 hour, then we add a drop of dye, and then we examine under microscope. If patient serum has antibodies, then what will happen, that it will not allow the trophozoite to get stained. So if you see less than 50% of tachyzoids or trophozoites are stained, that means the result is positive. But you see that most of them, 90 to 100% of them are stained, that means patient does not have any Toxoplasma antibody. What could be the treatment for toxoplasmosis? Treatment for toxoplasmosis, in case of congenital toxoplasmosis, you can give pyrimethamine and sulfadiazine, and both this drug will decrease the folic acid level, so we will also give a supplement of folic acid for 1 year. In case of immunocompetent patient who has only lymphadenopathy, nothing is required as such unless very severe symptoms are there. Otherwise, in case of ocular toxoplasmosis, pyrimethamine and sulfadiazine or clindamycin for 1 month can be given. Prophylaxis. It starts with cat feces, so avoid contact with cat. Proper cooking of meal, hand washing, screening of blood and blood products. There is no vaccine which has been developed yet. Difficult to control due to wide range of reservoirs. Any animal or bird could have it. But specific prophylaxis, for example, in case of immunosuppressed patient who has CD4 count less than 100, as in case of HIV, you can give prophylactically cotrimoxazole or dapsone pyrimethamine, and you can discontinue this prophylaxis when CD4 count boosts up to 200 or more for 3 months. So in next session we will do acid fast protozoa, that is Cyclospora, Cryptospora, Isospora and Microspora. Till then, goodbye.